Thank you very much for joining us today. And we'll be talking about, of course, your work, but also the launch of your new book. Can you tell me something about this very interesting approach you're teaching and writing about?
Do you mean the early trauma approach?
Yes,
Because I have several different things. All right.
I know. Yes, yes, yes.
The early trauma approach was initially developed by Katie O'Shea, and we've been collaborating on it since 2006. And she got me involved because of my work with complex cases and dissociative clients. And so I've been spending the last decade figuring out how to extend the method to the more complex cases.
Mm-hmm.
But it's a really interesting method because, of course, those of us who are EMDR practitioners are completely sold on the power and benefits of standard EMDR protocol. But the challenge in using it with very early trauma, where there's no picture memory, no explicit memory, no narrative perhaps, except what the client's been told, or a vague felt sense. The question is, how do you modify EMDR so that you can know where you are, what you're doing, and when you're done? And also how that the other challenge, or one other challenge of using EMDR in the very early time period, is that when people access, if you're so fortunate that you're able to help the client access very early trauma, when they access it, the problem of dual attention awareness is even more challenging because they might not realize that they're in a memory. So if you're doing standard EMDR on the fiery car crash at age 30 and they see the tractor trailer rig at the moment of impact, they realize that they're in a flashback. But when there's no picture memory or narrative, then when they're in the memory, they might just experience it with the infant's full overwhelm and even annihilation terror, which has to be the worst human experience. So the challenge of maintaining dual attention awareness and the challenge of knowing where you are and systematically proceeding is all something that makes it formidable. Additionally, when you're working in the early time period, people don't spontaneously, typically, shift into a resource neural net the way we love to see. How when people do standard protocol on something they remember, often they will just suddenly go, oh, I realize it wasn't my fault. And we go, another miracle. But when they're working in the very early time period, that spontaneous shift into a positive resource state is less likely to happen. So the nifty thing about the early trauma approach is that there are several preparation methods prior to where you actually process and repair trauma by time frame. But it's systematic, that is, it goes by time frame from the beginning, and you don't leave a time frame until the one that you're in is completely repaired. We repair in imagination, which is not to pretend that what happened to the client didn't happen, but rather we're providing the brain what it's been waiting for all these years in imagination. And the brain's not fussy about whether it's real or imaginary, and we know that from sports psychology. So those are a few of the things. There's much more to it, of course, which is why it's a 2-day workshop and a book. But those are a few of the things that are so interesting about this approach.
Nice, thank you. So if I'm correct, there are like two main categories in the approach. You have the basic affects of Panksepp that you can reset in a way before the actual work, and then besides that, of course, you have the preparation, but besides that, you have like the stepped approach, not like an EMDR where you have one discrete event, but you work in small time periods. So you have the basic
Yes.
resetting, and then you have the early trauma approach.
Yes.
Uh,
Well,
do
one
you always
the
do both?
resetting the. I'm sorry.
Do you always do both of them? Like always do the basic affect
Well,
before?
there's more than that. There are 3 preparation steps, and the circuits is one of 3 preparation steps for most people. And the first 2 are containment and safe state, which are those are not breathtaking. They're important. They shouldn't be skipped. But I typically don't spend a lot of time on that because it's the resetting the affective circuits that's so amazing. And that, you're quite right, that is based on the work of Jaak Panksepp, who established experimentally that we're born with hardwired subcortical affective circuits. That is, they're present from birth, they require no learning. So baby's born with those circuits, but not with a braking system. And the braking system, or down regulation of affect, is acquired in the attachment period. So when we do the resetting the circuit step, what that's intended to do is make, if those dashboard wires had to be clipped in the first year or 2 of life because, well, for any reason, typically that baby had to get with the program and not have needs and feelings, is what we see in malignant or highly neglectful families, then baby jettisoned the emotions, and this is a metaphor, of course, clip the circuits, clip the wires to the dashboard, and those emotions are cut off. Or sometimes we just see that the capacity for down regulation was not acquired. So people can go very intense on affect but can't down regulate. So when we reset the circuits, that is, we look at each of the Pankseppian circuits with objectivity. We have the client look with objectivity. That is, not the felt sense of the emotion, but what does that emotion look like? And then we process that so that they're clear and available for the intended use. Now, those are 3 preparation steps. Circuit resetting is the most complex, interesting, revolutionary, important. But then I must say that with the more complex cases, there's more than just those preparation steps. There's ego state therapy that's needed to get the self system on board. And often somatic therapy is needed so that the person can tolerate both positive and negative affect and soma.
So we can use it with complex clients. Can it be interesting to use it like with, the early trauma protocol, like processing a phase by phase, year by year, time frame by time frame? Can we use it with like people with panic disorder who don't have any related events in their lifespan, at least not they can remember? Do you think like that? So, okay, it's very difficult to trace. No float back is working. Perhaps I should try the early trauma protocol. Is that an option?
I guess if I saw only that one isolated symptom, I'm not sure that that would automatically point to early trauma approach. But if there was other evidence of that there might have been something in the attachment period. So if relationships are impaired, or there's an absence of self-confidence, or some of those other signs that some of the early developmental milestones were not well achieved, then I might look to that. When I hear panic disorder, and here again, I was trained cognitive behaviorally. I was trained to do David Barlow's chair spinning on panic disorder. That's the frame of reference I came from.
Yes.
What I've learned as an ego state therapist is that often, not always, but often, panic attacks are when there's whether you think of it as a neural net or an ego state or an alter that holds, and it's often rage, that's it's getting pulled close to the surface, and whatever ego state is in front, which is more compliant and pleasant, doesn't want to feel rage. so there's a push-pull going on, and the panic is about if the rage is going to get close to the surface. So I often will do an ego state maneuver to check that hypothesis. And like I said, it's not always true, but often you can find that there's a rageful or angry ego state that needs airtime because there's some injustice, and that can be addressed with ego state therapy and EMDR. However, if there were a combination of not only panic symptoms, but other evidence that there might have been problems in the attachment period, then I certainly would take the early trauma approach. And
do you mean explicit elements, like in the history taking? A client says, during birth I had a difficult birth, or my mother lost her mother at the time of pregnancy. Do you mean
those would be clear indications that you might expect? Whoops, a pop-up message here. You might expect that the early trauma approach would be helpful when there's events that are discernible in the history that indicate that there was early trauma. But also, if you just see evidence, if somebody says, I've been depressed all my life, or I've never felt confident, or I've always been ashamed. All my life I have felt shame. Well, the minute you hear all my life, that starts pretty young, doesn't it? Right. And so that and given that we know that babies are never defective in the sense that they all deserve love, then if they've had lifelong shame, then we know right there, just logically, we know something went amiss in the attachment period or in infancy because they've been holding shame all their life. And if they've never had a moment's peace, then anaclitic depression, as a psychoanalyst would call it, that starts at the very beginning. And we see it all the time in the early trauma approach, that baby gave up. Baby cried in concept terms. Baby felt the separation distress. There was the separation cry that should have triggered mom's care circuit. She should have come, and for whatever reason, she didn't. And baby gave up. If it's chronic disappointment, chronic hurt, chronic neglect, chronic abandonment, chronic anything that's malignant or I mean, there's neglect and then there's malignant harm, or by which I mean intentional and unintentional. That still wasn't clear, but
yeah, sure. You can have a good family, but in like the circumstances weren't ideal.
Thank you. Yes.
Yeah.
They're not always malignant. I mean, if there's 12 kids and mom has to go back to work and dad drops dead of a heart attack, then baby's neglected. And but what was I getting to? That if any of those early developmental milestones, psychological, emotional, developmental milestones, are not well achieved, then baby can give up, feel despair, feel ashamed, feel defective, feel chronically anxious. Generalized anxiety is a good example of something that seems to start very early. And when we do the early trauma approach, we're repairing it. We adjust their anxiety level downward, actually beginning with the resetting the circuits. But then when we hear the story of what happened and didn't happen for each developmental time frame and repair it in imagination, we are solving those whether they're big T or little t traumas, where baby took the lesson that he or she was defective or in danger or worthless. Those various lessons people take away that are the basis for personality disorders or other what DSM what used to be called Axis 1 disorders. We're repairing those. Those are remitting because we're we're repairing the injuries that caused them. See, I've come to think of the diagnostic manuals as a shrine to what happens to babies.
Mm.
You know, if we shook the diagnostic manual by the spine, have it be trauma, including developmental trauma, and reorganized it that way, then it's a different way of thinking about the symptoms that we see. But we're repairing those, and the symptoms remit, even the ones that we think of as very hard to address.
Yes, yes. All right. I saw also on your website, excuse me, the website from Katie, and perhaps you too use it in that form, like several days of early trauma protocol. But can I, as a EMDR practitioner who has only 1 hour per client, 1.5 hours per client, can I do something with the protocol and the approaches also in that short time frame?
I think that you can. It's harder. The shorter the appointment, the harder it is, because you really need time to move the person out of their left hemisphere and into their right hemisphere and drop down into the felt sense of the body, because they need to be attuned to what I call the dust bunnies in the body. They're like nuances.
Okay. Yeah.
And I'm realizing that some of these idioms are not going to translate well, but
I understand.
but they're subtle nuances in the body. And so if people are busy thinking about traffic, then it's hard to get people to drop down. So a 90-minute session, you can get some of this done, but you need time to drop down and time to bring them back out, because you can't have them leaving in anything less than a fully alert, roadworthy ego state and state of being. It's optimal to have a half a day or a full day because then you're not so much arguing with their left hemisphere. They get with the program. They understand that the task is to drop down. But I recognize that not everybody can work that way. So I think an hour, if you're very gifted, you can get them to drop down. But 90 minutes, I'd say, is more doable.
Okay.
But they have to realize they don't get to talk much. Any session that's spent in the early trauma approach is not a gabby, chatty left hemisphere session.
Just to summarize our whole associative discussion on on Skype, on Zoom, sorry. The early trauma protocol is just not just, but it's part of the whole experience. You take somatic therapy, you take ego state therapy, you take early trauma, you take EMDR, and you combine it in like a package. Something like the best package you can give to your client.
Yeah, well, the way I think about it is, if EMDR is the light bar, then these advanced skill sets are the legs of the tripod that hold up the light bar. So thank goodness we have EMDR standard protocol, but for the more complex cases, we need advanced skill sets. So we need to be able to do ego state therapy when there are defensive structures that would block the processing. We need to be able to do somatic work when people learn the body's not a safe place to live, to help them to get hooked back up and to help resource them to expand their window of tolerance so they don't get dysregulated or flooded or shut down. And we need the early trauma approach to address those injuries that are before explicit memory. And I guess I also, in addition to the 3 legs of the tripod, now in my mind's eye, that cartoon also has the power cord that plugs into the wall to represent we need to be attuned intuitively and to our mirror neurons. So that's sort of representing the the energetic end of things. We need to be attuned and resonant to what else is in the relationship field and the energy field and utilize that as part of it.